Research has clearly pointed out the effects the context we create in treatment have on outcomes. If you watch a master clinician in action, you will see if you look beyond the techniques. Watch how confidently they communicate both verbally and non-verbally. Watch how confidently and comfortably they deliver techniques or exercises. The performance they put on in front of a patient can have a big impact on how well the patient will respond to an intervention. This is why you can deliver the same technique or exercise and get different results, even though you felt you delivered it exactly the same way technically. If the performance matters, then it would make sense that we should aim to get better in our performance skills. Now, before you light me up in the comments, ideally the context we create is around an intervention that has scientific plausibility and merit, but it should give us pause to consider that maybe some of the interventions out there function mainly, if not fully, on their performance aspects. So this brings us to this week's episode where I interviewed Logan Buckley. I got to know Logan in our Modern Pain Pro community, and as we had discussions around ways we can improve communication, he let me know he was involved in improv. To me, the best clinicians are able to be master improv performers. They're able to adapt their conversations and interventions to the uniqueness of every individual. When explanations or interventions fall flat, they're able to adapt and adjust on the fly to find a positive road forward. In this week's episode, we discuss how improv can enhance our communication and how it's a huge help when we navigate the uncertainty and complexity we face in the clinic. Logan also shares how his focus on authenticity versus mimicking his mentors really helped him grow and improve. As always, don't forget to subscribe wherever you're listening or watching the podcast so we can spread a better message around pain to more people. If you want to go deeper on conversations around a topic like this, make sure you check out our community at modernpaincare.com/community. Now on to the episode.
This is the Modern Pain Podcast with Mark Kargela.
Welcome to the podcast, Logan.
Hello.
Good to have you, man. We got to know you a bit as you've kind of joined our community, Modern Pain Pro community, one of our founding alpha members. So really grateful for you that. But the nice thing about the community is I've been able to get to know you and some of the other members and kind of hear some of your unique backgrounds. And one of your unique backgrounds we'll get into. But before we do that, I'd love if you could kind of introduce yourself, kind of where you're at, what you're up to, how far along you are in your physiotherapy journey.
Yeah, I graduated. I have to think back now. I'm at that point where I'm like, how many years ago was it? So I think I've been out of school for 5 years, graduated in 2018, went into outpatient orthopedics, and was there did residency, maybe 6 months out of school, with Upstream, and then decided I got a little burnt out and decided to leave. I did pediatrics for a year and a half. And then I kind of had this urge, my passions working with people with persistent pain. And I kind of had that urge keep on coming up in the year and a half I was in pediatrics, and found my way back into outpatient orthopedics. Got my OCS this past year. So that was a big benchmark. I kind of set a goal for myself. Just have been kind of fumbling along like all people, I feel like, my first 5 years, and working at Providence in Oregon right now.
Awesome. So it's interesting, existential crisis journey that, it seems to be everybody's some part of their career journey where we have this like, man, I'm kind of burning out. I don't know if this is my gig anymore. And obviously you found your way back. The thing that got us to this conversation is, we talk a lot about communication and how crucial communication is as part of our work as physiotherapists. And it's a skill, right? It's not this, we call it a soft skill, but it's probably the hardest skill we learn. And to be able to be nimble and agile with your communication is crucial as well. And then you said, well, hey, I do some improv, and I've known some other folks. I want to say our friend Sandy Hilton does it. And there's other folks I know in the physio profession who've done improv, and it just makes so much sense to me of why that is such a helpful thing to do to improve patient care. I'd love if you could kind of get into how that even came to be. Is that something you've done as somebody in high school, or when did improv enter your existence?
So I was a senior in undergrad, and I needed a throwaway class to stay a full-time student. I had gotten into physical therapy school. I needed a throwaway class. I had to take an acting class or an arts class earlier in my undergrad for my arts and science degree. So I was like, you know what? I know the acting teacher. She's really cool. She has this improv class. My siblings never thought I was funny. So I was kind of more also doing it to be like, I think I can be funny. Let me try this improv thing. Kind of to stick it to my siblings a little bit. I'm one of 5 kids. So it was really more just like, screw you guys. I am funny. And I just took the class, and it was my last semester, and I really, really liked it. And I fast forward to physical therapy. I had 10 days between finishing undergrad and starting physical therapy school. And I remember our summer semester at Maryland, we had to do anatomy, and we did 9 weeks of anatomy. So we were in the cadaver lab nonstop. I just remember getting out of that class, and all of my classmates they would get stress relief from working out. And I never had that. I am not one of those people that gets a lot of stress relief from working out. And I was like, I need to, if I will stay sane during PT school, I need to find another outlet. And I was like, I just did this improv thing my last semester of undergrad that was really fun. Let me look if there's improv classes in Baltimore. And I looked them up and joined a class. And at first I was like, oh, this is just going to be a stress reliever. This will be fun. I didn't really think anything of it. And it ended up not just helping just socially and getting that stress relief, but it led to some of the best friendships I've ever had. It gave me community outside of my physical therapy school classmates. It gave me something to look forward to at night instead of studying. And then now, as we're talking, like, we'll get into it, but it ended up as someone who's socially awkward and is diagnosed with a learning disability. It has really helped and impacted how I communicate with people, and how was or has been seen as a deficit of mine for a long time, I think now actually in my practice is probably my biggest strength.
Yeah, I mean, just getting to know you in the brief time I've gotten to know you, I would have never like pegged any social awkwardness or any of that. And I think it's obviously a skill you've built. And I can just, in my story a bit, I think I alluded to it in some of our meetings we've had, is like I used to have massive social anxiety and probably would say social awkwardness as well. And it was just one of those things. I didn't do improv, but it kind of got just to where, hey, I got to get good at this, and just got buried into like doing enough of these things and public engagements and things to where, now I feel a lot more comfortable with that. So, I mean, good on you for taking the bull by the horns there, and really, like you said, I would agree. It is definitely something that comes across as a strength of yours. Now, when we look at this as a physiotherapist, I'd love if you can kind of maybe look back as a DPT student, because I think there's this belief as a DPT student, and I'm happily if you disagree with any of this thought, but I just know as me as a DPT student, I was like, the communication was kind of secondary. It was like I got to find the magical thing with my hands, or with some amazing special test or exercise was going to just be the key to solving these issues that patients came in with. How has that, looking at improv and its kind of role in what you were going to do as a physical therapist, how's that maybe changed over time? How have you seen that be maybe and maybe you didn't have that, maybe you saw communication early on was a crucial part of things, but I'm curious how that kind of has morphed in your journey as a physical therapist, where you've kind of viewed its place as far as helping your skill set.
Yeah, it's something I don't think I thought about too much. I think in physical therapy school, I was just trying to learn as much as I could. Uh, I think I knew that I was a likable person, and although like have a history of like learning disability and stuff, that I got along with a lot of people. Um, but I don't know if I really picked up on the importance of language and communication, maybe a little bit near the end of our second year of physical therapy school. We got a little bit of pain neuroscience education, like stuff we got quite a bit of it. And it was like, oh, communication matters, and like placebo and what is a nocebo. And it's like, oh, we can actually affect patients with our words. And then you kind of go into clinical and you're just picking up everything that your CIs are doing and trying to survive. And I think once I got out of practice, I really honed in on trying to be a better communicator. Like, I was so worried about like nocebo stuff early on in my career that there was points where I wasn't thinking about it, but then I got like way overthinking about it to my detriment. And then over time, I think it was actually coming back. Now that I'm thinking about it, I think it was coming back from pediatrics, where I had to do virtual pediatrics for a year and a half almost. And then going back into ortho, that I really started to hone in on communication. And I worked in early intervention, and we were a coaching model. And so I had to make differences in kids' gross motor skills with just talking to them over a screen and giving parents ideas. And it was way more about my connection with the parents than it was, I think I gave the best interventions that I could, but sometimes it was just being their support system. And I really started recognizing how that helped. And then going back into orthopedics, kind of changing that and honing in on some of what I tell patients or how I was communicating, honing in on my pain neuroscience education and knowing that I can, and then having success with it. I'm kind of rambling, but one thing that makes me think of was I recently have thought, I'm so glad I did a lot of manual therapy early on in my career, because that was a way I could change people's pain pretty quickly. It was a way to get comfortable with getting buy-in from my patients. And it gave me the freedom to work on my language, gave me the freedom to work on how to say things, how to present an exercise. And so when I was ready to, or when I started to like drop like manual therapy, or not drop it completely, but like bring it less into sessions, I was having more success with not even doing manual therapy on a first visit, and people coming in and saying, oh yeah, this was great. And I just presented an exercise, I think, correctly to what that patient needed. But I wouldn't have been able to do that without the manual therapy allowing my language and communication to catch up.
Yeah, no, I think, you sound very familiar as far as I definitely can relate to that journey with manual therapy, as far as that was our inroad to kind of communication with a patient. And like you said, gaining buy-in, I think that still can be that for patients. I do agree that you bring up a good point too with like this. I think there's this implicit assumption that it just has to be part of the engagement, especially first on, like, we got to get that buy-in and stuff. And it sounds like you've had a similar experience where, yeah, sure, there are times where, there's expectations, there's various contextual things that would make maybe hands-on care, a possible good choice first visit. But I think this pressure to do it visit one just has kind of eroded. I think research has put it in perspective, and it sounds like you've obviously put it in perspective too, to where sometimes just a good therapeutic alliance building session of like, hey, listen, validate what they're going through, come up with a game plan, show them that you're invested in their goals and that you truly understand their why, what they want to get back to. And I find similarly, like, it doesn't have to get so hyper technical with manual therapy. I mean, again, there's a time and place, and we can definitely examine to see if there's things that might be worth passively, doing a symptom modification procedure. But yeah, I definitely have found the same thing. I'm curious with some of your persistent pain patients, because you mentioned, I think, I don't know if maybe the improv background kind of makes you more, to me, I just see that population as an immense challenge of like improv, because you never know what the context and story. To me, it's like an improv where, wow, what's going to come in the door? How am I going to adapt to what that patient's unique story? Oftentimes some very challenging stories that come in. I'm curious, like just specifically with that population of a persistent pain patient, where gosh, the story coming in and the context they bring that you have to improvise and try to fit yourself to, and then the session to session fluctuations that can change, pretty mightily with patients. I'd love if you could share how you feel that improv background has served you in that role.
Yeah. So this is actually a great setup question for all of that. I've been thinking about this recently since you asked me to do this podcast. I'm like, what is it? And I think I've narrowed it down to a couple of things. The first thing, anyone that knows improv, or maybe even people that don't know improv, know that the fundamental rule, the first rule of improv is yes and. So you say yes to your scene partner, and then you try to add something to the scene. And I feel like when I have people with persistent pain, I kind of think of it like I yes and as much as I can so that I can but later. So in improv, you're not necessarily going to, the rule is like you don't want to but when you're trying to change someone's mindset about pain, you're going to have to say but at some time. So for me, it's yes anding or as much as you can, and so you can but. And that's something I think I actually do quite a bit. Or even when I give pain education, I say, yes, I understand what you're saying. Yes. Like people with hypermobility, it's like, yes, I know people with hypermobility have more pain. And then my little and is, do you mind if I give some education about it? So I'm yesing, validating, and then that and is, then I give them the pain neuroscience education, see how they respond. And I ask, like, how does, like, any questions? Like, when I heard about this, my mind was blown. And just being authentic with them, like, yeah, it's wild. It was hard for me to like comprehend at first. Like, I just threw a lot at you. And so then sometimes people are like, no. And then that's also where the improv is like, okay, they denied kind of that. How can now I need to continue I need to go back to yesing and just yes, yes, yes. So then I can try to introduce it again later when the time's right. And I think that's definitely in not having expectations too. I feel like early on in my career, I expected patients, like I gave this, they should come back and they should feel better. And you're kind of setting yourself up to not be flexible in that session. This might be a little bit, I do chart review to make sure there's nothing serious going on, but I try not to do like a deep dive chart review because I want to hear the patient's story. And I feel like I'm more adaptable. There were so many times early in my career where I would read the chart review and I thought this person, they were coming in with persistent pain. I was like, oh my gosh, this person is going to be this or that. This is going to be a hard case. And they come in and they're like the most lovely person and are so adaptable to change and like take everything so easily. And I was like, oh, and I went in with just this negative perception of what I was walking into. And so sometimes I feel like there is an over chart reviewing, in a sense, because we can kind of get a picture of what this person is in our head and have judgment on that. And I think coming in with no judgment is actually really important, specifically with those people with persistent pain. So those are a couple of like that yes anding. And then another thing in improv, depending on which theater you study at, there's this idea of game. So the game of a scene is the unusual thing. It's that funny thing in the scene. And it's your job to pick that up. So if my scene partner does something weird, it's my job to either match it to like increase that weird or even state like, hey, that's weird. And then that's usually where the laugh comes from, is that pointing out. And I feel like with my patients, I'm always listening for that weird thing that they're trying to tell. What are they actually saying? So I'm trying to think of a good example of this. Patient comes in and is like, yeah, I didn't do my home exercises. So what I actually hear in that is, I don't like my home exercises. So what are they actually saying? What's the weird, or you're trying to pick up things that are unique to them. I think differential diagnosis, this helps a lot too. And it's like, oh, I've been coming in with knee pain. I'm a CrossFit athlete. I don't have any pain during CrossFit. And, but I have pain when I'm sitting for long periods of time. And it's like, okay, is this a patellofemoral issue? Or that doesn't sound like it matches. Like, what else could it be? Is this a nerve issue that we're like, they don't do well with long periods of sitting and we need to get the nerves moving a little bit? I had a patient recently come in with like running, and it was similar. They were a marathon runner, and they just, things didn't add up. And then differential diagnosis, I was like, let's check your femoral and saphenous nerve, and like did some nerve glides and felt better. And they had been treated with quad strengthening exercises before and weren't getting better. So like things like that with differential diagnosis, I think it helps. Picking up on things that they enjoy. You might not ask it, but they say something of, oh, I used to love doing this activity. And to me, I'm like, oh, that's interesting. Why'd you stop? So I think that idea of game and like understanding what the unusual thing is, or what are they actually trying to say, is something I've really picked up with improv.
Yeah. No, I love the fact too, like, there's this, you kind of allude to it a bit as far as this almost like scripted way of, especially when you like do a big chart review where you're almost just reading the script and the plot line that's led up to there. And then sometimes it like weaves you into that bias of like, this is what I should expect. And, as a, young physio, you're going to use that to really, and it's still good to have hypothesis development. Don't get me wrong, where we're trying to rule out like red flags and all those things. But I do think, and you point out very well, that it can sometimes preconceive, and it almost biases your conversation, and it should to an extent. Like, hey, we need to ask certain questions to rule out certain things. But again, this pursuit that we have as like traditional biomedical minded clinicians is to kind of really have this A plus B equals C. So I just got to question out as many of the A's and B's as possible to see what's causing C. And yet there's obviously, we know pain's so much more complex, and the ability to go unscripted, where you go into this encounter with almost purposeful curiosity. And like you said, not just taking that answer for like, what's behind that? What's behind this patient saying I didn't do my exercise? Because what do we do as clinicians early in our career? Non-compliant patient not, patient failed bout of therapy, that, it all gets lumped on the patient, where obviously there's something behind it. You point out some good thoughts on it. Obviously the patient doesn't value them enough, or something's not going right enough to where they feel like that's worth their time, or obviously there might be some other things going on in their world, but to have some purposeful curiosity of not just assuming, there's something wrong with this patient, they're not compliant, they're just not listening to anything. So somehow that your interaction hasn't given them the reason to want to do it. So what's the missing piece there? So have you found that kind of really improv skill set really generates that purposeful like curiosity and your willingness to kind of delve into that muddy gray area? Because improv kind of is the whole point of it. It's muddy and gray, and you just see what comes out, and you make some interesting interactions with the audience and with your fellow cast members and things. Now you're doing it with patients. How do you feel like that helps you navigate that muddy, uncertain gray area that as much as we want to paint, and in school we paint this very black and white picture of, well, you're going to put this on A, B, C, or D on your Scantron on your board exam, and it's going to all be this black and white way of looking at the human in pain, and yet it is not what we see in the clinic. So I'd love to hear what your thoughts are as far as where you feel that improv has served your ability to be comfortable in these type of situations where it's muddy and it's gray.
Yeah, I think that's a really good question. When I think of those muddy, I think it like with improv, you have to be willing to fail. And the amount of times I've done improv for, I think now like 7 years, the amount of times I've gone on stage and ate shit is like infinite. You go swinging big, you think you have this great idea, and it just falls flat. No one laughs. And I think when you're coming in with those muddy situations, you just can't be afraid to fail. I think that's what it is. Like you, and also coming in knowing that like you might not have the answer. I think that's really good. There's sometimes in scenes, the scenes that I feel there's sometimes I just don't know how to respond. And it's like, yeah, I'm making this up on the spot and that's okay. And giving yourself freedom to be like, yeah, I didn't know how to respond to that. I did my best. It did not get a laugh. And then but I'm not going to dwell on it in the next scene. You can get informed by it. So the next time you are more prepared or you feel like you can practice. And I feel like it's those muddy conversations, you just have to have them. And you just have to go in with open-mindedness. You have to go in with a sense that it might not work out. You might get a patient mad. But that's that's part of the game. But maybe it can turn into something where that patient recognizes something they've never recognized.
Yeah. And it only happens if you're willing to put yourself out there, right? It's only happens if you're willing to get in those uncomfortable conversational spaces that exist in a clinical encounter that, again, might shine light on something that is a major shifting point. It also might land completely flat, like you said. I think we can all probably relate. Anybody that's had any conversations clinically with somebody, has had them fall flat and fail. I'm sure we could have a whole probably season of episodes of our of failed efforts and attempts, especially with pain science and the thoughts of like, I'm just going to educate people's pain away, and that's all how I think some of us think about it early on, and then we realize, okay, pump the brakes on it. It's part of the discussion, and it's part of the the plot, but it definitely is not. As with anything, it's not going to be a standalone one shot, and with patients making these 180s rarely, if ever. So no, I appreciate you sharing that. Oh God, there's so many places we could go with it. Where would you recommend somebody as like an early career clinician, somebody who's really, maybe there's somebody who has social challenges and some, we spoke to our individual challenges on the social front. How would you recommend somebody? I mean, maybe it is improv, but what do you think are some things people can do to get more comfortable having these type of conversations and getting into some of these muddy waters and trying to find comfort with it?
Yeah, I feel like for me, and I was actually thinking along these lines of possible questions you would ask. And for me, it's really finding out who you are as a person and who you are as a clinician and what you're comfortable doing. I think back to when I first was coming out as a physical therapist or out of grad school. I was I was in the closet, like I was gay, but I wasn't out. I wasn't myself. I was depressed, and that shows up to clinic. And the more in the last 5 years I've become more comfortable with myself, the more comfortable I've been in those conversations. So for me, improv was a great way it was something I found joy in. It's something that resonated with me, something that I used to love doing theater when I was in middle school. So it brought something back that I enjoyed. So it was authentic to me. But I also know there's a lot of people that that's not authentic to. And I would be naive to be like, just take an improv class and it will be perfect. And you'll be better at communication. I don't think I'm not naive enough to say that. It's finding, like, working on yourself and working on who you are. I really feel like in the last year and a half, I've really become a better physical therapist, and I've really become a better, actually, improv comedian, because I've more and more had my own voice. I'm no longer trying to mimic others, and I'm actually informed by others, but now the voice is my own. So like when I have those tough conversations, it's coming from me. And I feel like the only way to get better at it and find your voice and what makes sense to you is actually jump into the discomfort a little bit. I think I know me. I am an open book. I'm a pretty honest person. I don't try to hide my emotions that well. You're talking to someone who, if a patient asks, how's your day? And I'm not having a great day, I'll actually say, yeah, I'm not having a good day. But I recognize that's not everyone. So I think that part of me allows me to have those conversations a little bit better. But I think it's finding what works for you. Who are you as a person? What makes sense to you too when it comes to pain neuroscience? Like, that's a hard thing to conceptualize. So as a new grad, don't beat yourself up if you don't have the perfect words for it. Try to find what makes sense for you. And if it makes sense for you and you can educate it, and educate patients, it's going to make more sense to them. If you try to do it a way, you can be informed and you can mimic definitely early on to help find your voice, but it's, I would say, as much as you can, try to just be yourself. And I know it might feel like a dumb answer, but being yourself really helps in those situations.
I mean, that definitely resonates with me, because I'll just kind of go back to my journey with pain science, for instance. I took a lot of it, gobbled up Gifford and Mosley and Butler, and then was with Adrian Lowe's group for a bit. And I remember having those flashcards and having Adrian's stories and stuff. And I felt like I was trying to be Adrian Lowe in the treatment room and nothing wrong with those stories and those metaphors and things, but I didn't feel like I was being authentic or organic. It was something where I felt like I still was pulling myself at trying to be something that I wasn't necessarily my normal, natural self. And I agree. I think patients sometimes read that where, I get the premise behind the Why You Hurt box. I think it's definitely has been an overall help, but my only knock on it is it's just this kind of way to kind of be this unauthentic, non-organic, stripped from the context of a conversation and with the relationship with the person, and get into this. Well, your nervous system is a car alarm, and you point to the picture, and you just have this scripted way of going. So I love the fact in the discussions around authenticity, and I would agree too. I think we do mimic, just to kind of mimic our mentors and mimic the people that we kind of model ourselves after. Probably our parents as well as we grow up, and we can probably look at a lot of people who we've mimicked along our journeys. But in the end, we have to find our own voice. We have to kind of fly the nest a little bit and kind of get in that discomfort that is life. And it definitely parallels more than just the treatment room, for sure. But I love what you said as far as really feeling like you weren't mimicking anybody, you're being your true, authentic self. And that really has allowed you to really grow clinically and have more success clinically. I think I would agree too. Patients see that, and they see the authenticity of somebody in front of them versus somebody who's struggling to mimic and figure out their own voice. And it's okay. I agree. You got to lean into that discomfort, you got to lean into that mud, and you will find it. You just got to be willing to put yourself into discomfort to find it. It will be failed conversations. It will be pain science stories that just make no sense to you, even reflecting back. That I know I can reflect back on some of mine attempts at metaphor and things that like, that did not go well. But man, I'll tell you, those are the priceless parts of your journey. I mean, you look back and you cringe, but man, if you don't have those, you don't grow. I'm sure you have probably a litany of your own, challenges and missteps along the way. What would you say to some of those clinicians who are struggling to? I know you've already talked about the authenticity part, but I mean, when it comes to pain science education, for instance, what have you found helpful to kind of, and you've alluded to it, having your own voice, but I'm curious, any other pointers you'd have for folks who are trying to kind of find their own voice versus the flashcards and the canned metaphors that are out there?
Yeah. So something that helps me, one, I try to give it a lot. Like the amount of times I attempted to give it for people with acute pain, for people with chronic pain, for people with subacute, like I tried it a lot, tweaked it, modified it, see what response. If a patient recognized it, like I tried to pick up like in my subconscious brain of like, okay, this person responded well to how I said this. Maybe let me say it to this person. This type of personality doesn't respond well to this. Which one should I use? Reading body language, trying multiple ones during a session. I had one recently where I tried the car alarm, or I used the alarm system, didn't work. I switched going from a dark room to a light room, and something clicked. And I just switched the analogy. And I didn't give up, but I just switched it, and like something clicked with that one. Not being afraid to try multiple ones. I would also, I think also trying to tie it back. This is going back to that unusual thing or that game, tying it into a patient experience really, really helps. So being able to listen to what a patient is saying and then being able to pick that up, and maybe they didn't fully get the analogy you used the first day, but they say something where they're stressed out and they're in a flare up, or they had a loss in the family and now their pain is significant. Being able to pick up on that quickly and like, hey, remember that alarm system analogy I used a couple sessions ago? Yeah. Do you think this may be impacting that right now? Impacting, and they're like, oh my gosh, yes, I didn't even think of that. And then being able to, maybe it's not your first attempt, but as you continue treating, being able to pick up on what your patient's saying, being able to pick up on things and tie it back to what they experience is where you probably have the most success and what I've gotten better at over time.
That's great points. I think the one thing you talk about there too is just like you're kind of using, we call it like I remember in fellowship, it's pattern recognition. You're trying to see what works with what patients in what context. Normally, traditionally, like what technique and what special test or whatever, type of thing. But you can see, and I've stressed this over and over again when we teach, as far as you got to look at communication like your most powerful intervention. You mentioned not even just the verbals, the nonverbals, you being able to read it from a patient, but also how you're portraying yourself to a patient nonverbally and all those things. I think it's powerful stuff that we take for such granted. But I think if you watch master clinicians or clinicians who are really good with, they're often amazing with people, and they've developed probably these improv skills kind of implicitly just through experience and things. I think being more explicit with understanding the role of these skills, these soft skills, which again, I'm not a fan of that term, but and if you can just look at that as like, man, I need to hone this part of my craft. Because I don't know about you, I'd love to hear your thoughts on, because for me, I feel like when I've really prioritized that, my need to be this toolbox laden, 15 million techniques to do things really kind of got stripped away to like still do some of the basics well, and some of the, get people moving back to ways they want to move and calm things down, build them back up. That's about as complex as I do. There might be some manual therapy stuff in there to maybe help that journey along in the right context. But what's been your experience with the complexity of your communication versus the complexity of your intervention?
Oh, yeah. I think it's like, so I have a hard time, or even when I have like students shadow me, or I had a physical therapy assistant student last year, and it's hard to even like put into words how much I'm thinking about language when I'm with a patient. I might implicitly on purpose leave a portion of my pain education completely out, not because I completely forgot it, because I didn't think it would be good for this patient at that time. But it comes off like smooth, and like nothing was, like I didn't make any different choice in what I was going to say. And it's hard to teach that. And it's hard to be able to like, oh, so, during that pain education talk I gave, how I didn't do this. Well, it's because of this and that. And yeah, to that point, the more I've gotten, I feel like better with my communication, the more simple my even exercises are. I feel like I feel like I actually had my PTA student, I giggled at this when she said it, when she was with me treating. I think it was her first week. She's like, oh, I didn't even think to bring exercises I do into the gym into working with my patients. Because most of the exercises I were giving were just modifications of squats, deadlifts, like front raise, lateral raise, overhead press, like nothing crazy, nothing like over the top. And her words were like, oh, I didn't even think that I could bring in exercises that I do into the clinic. I didn't think of that as physical therapy exercises. And I was like, oh, and I even think myself, as I've gotten better with communication, more and more of my exercises are pretty, like they're not crazy, and they're pretty simplified, and they're effective, and we get the job done.
Yeah, no, I would completely agree. I think, a lot of times too, is we're getting into act with Brownie in our group right now, as far as this whole values based and really pointing things to values. And then like, to me, it's like, what are your values? What does life need? What would life look like if pain was less of a barrier? Once we identify those things, it doesn't need to be simple. If somebody wants to, just do things that look like the thing they want to get back to, and then do more of the thing you want to get back to. I think we make this assumption that there needs to be some sort of complexity. And I think, to me, it just goes back to where we misplaced the complexity of pain. We used to think it all lied in tissues. Therefore, tissue narratives got so overly complex and went into all sorts of fairy tale stories of things we could feel with our fingers and rib flare, all the, things. I'm sure we could all have a support group discussion about the things we were used to think we could do with the body. And then we missed the real complexity, which was that human being in front of us and how they're navigating this pain situation, and then how we can weave into that. And I think it's probably a lot more about getting a human, and especially the research still kind of tends to show that expectations, psychosocial factors, all these different things have such a more mediating effect. Not to say there can't be some times where mechanical treatments can't be very important. I definitely, when I had my herniated disc, there were certain mechanical things that were not happening for me, and certain ones that definitely made me feel better. So, but it's just, obviously we're talking in certain contexts, oftentimes with some patients. But again, we don't know that until we get to have these communications and discussions with unique people and get to see and not make any assumptions with that chart review you talked about early on, that it's going to be some mechanical problem strictly, where we're going to give the patient a stage and our undivided attention and that purposeful curiosity that you bring to an encounter that I think your improv career has really, helped you develop. You can hear it in the way you talk about how you interact with patients, that there's that purposeful curiosity. And I one more thing, and then I want to kind of wrap it up and let you kind of finish off with anything you want to mention. But you mentioned this kind of, I always feel guilty with students, because we have students that come in twice a week with us, and early career Mark would just wow with like, look at this manual therapy technique and look at all these fancy exercises. And I feel like I don't want to say vanilla, but it's not special, but I try to get to across the students, and I don't feel like they're in a space. I know I probably was definitely not in a space where I wanted to learn how to manipulate, man. I wanted to learn how to do these amazing sports medicine exercises that if I would have went to see or shadow me, I would think this dude is so basic and he's so like old school. Like he doesn't do anything sexy or fancy. And I mean, I occasionally manipulate still, like, oftentimes more expectation based stuff. But yeah, it's interesting how our practices shift over time. And when we prioritize kind of the things that we tend to be the secret sauce that really move the needles for people. I'm curious, anything you want to kind of leave us with today I want to respect your time, and I really appreciate it. I've enjoyed this conversation immensely.
Yeah. One thing, just I'll piggyback off something that you said. I think it's also important to recognize when exercise isn't the answer. And I've been even doing that more and more. I specifically remember a case where the exercises flared my patient up. But when she didn't do the exercises, she was fine and could do her daily life as she needed. And I said, okay. And she respected me so much for it. I was like, yeah. This doesn't work for you right now. Exercise is too much. It's not your priority. We don't need to do it. When you feel like you're ready and you need some exercise education and you need to get back to it, let me know. Here's my card. And we had a great rapport. There was nothing wrong with that interaction, and she actually left happy.
Yeah. Yeah, I think we have this like implicit or just assumption that it has to be part of the gig. We're, in a lot of the research, manual therapy and exercise, where it has to be part of the gig. But I think, you obviously being a person-centered clinician can hear that, well, exercise doesn't like it and it makes everything worse. And can we structure some things, and I've gotten creative with, maybe it's not technically exercise, but it's the person pursuing the things that make them happy and feel like they're, more the person that they want to be, that pain's not stopping them from being as much anymore. And I find that stuff to sometimes be more powerful than probably any exercise I've ever prescribed in the past. So, man, I really appreciate your time tonight. Anything else you want to leave us with?
Yeah, I think for me, what really helps, I think I put it, is mimic your mentors, mimic them at the beginning, figure out but then really spend time and enjoy the ride of finding what works out for you. I think I stressed out too much about not doing things right. And now that I look back in my practice, it's like, oh, no, that was all, it was fine. I was just finding my voice. I was finding who Logan practices as, what makes sense to me. I'm still doing it. We're learning about ACT here in our group, and I'm in the same process of okay, I think I understand what ACT is, but I don't know how I need to frame it. I want it to come more casual because I have more of a casual conversation approach. How do I do that? I have no idea. I'm feeling this is formal. I have failed quite a bit trying to implement it. So I'm still on that journey with a new, different method to think about. So just don't beat yourselves up too much. I wish I still beat myself up too much. So I'm going to tell others not to.
No, that is great advice, and I think words we could all probably take heed of, just because I think we do tend to be our harshest critic and feel like we always have the answer. And you've already talked about being willing to be authentic, and I don't know, it being a word that comes out of your mouth. I know I've gotten more comfortable saying that, and I would agree. I think patients respond actually strangely really well to that. I think they respect it, that you're being a real person and not somebody who's this paternalistic, dictator of all that is right and the patient's all wrong type of, so it kind of levels with the patient. So again, thank you so much for your time today, Logan. Really appreciate it. It's been awesome getting to chat with you. I'll probably pick your brain more in our group about some more improv skills, and we'll stumble our way into getting better at ACT together. No problem, man. Well, you guys who are listening, we'd love to have you subscribe on wherever you're listening to the podcast. If you're watching on YouTube, we'd love to have you subscribe and maybe this episode so we can spread it to more people. But again, we want to thank you for listening, and we'll talk to you all next week.